Good morning, everybody, and welcome to this webinar on the implementation of the lymphedema prevention pathway. I say good morning, that's for us guys in the UK. It's good evening for Louise Presentation, who is joining us from Sydney, Australia. Just before we get going, the session is being recorded, which you'll get access to afterwards. So we're going to send out a link after the session with the recording so you can watch back at any point. We do have a question and answer session, so we're going to start off with a presentation from Louise and then followed on by Ali, and then we'll have some Q&A where you can ask whatever basically you want. There's a Q&A function that's at the bottom of your screen. If you put your question in there, we shall get them answered for you. Otherwise, quick introduction to myself. My name is Dominic Smith and I'm the Clinical Application Specialist at PhysiQuip. And for those of you who aren't aware of PhysiQuip, we are a medical technology company who work with people all around the world to bring some of the best technology to the UK market. And hence why we're looking at this pathway as well. Something that's internationally recognised, and we wanted to bring some more information to the UK for you guys in terms of practical elements and implementation. What I'm going to do is I'm just going to hand straight over to Louise Presentation, who's going to start off with her presentation, go through her information, and then through to Ali, and then we'll get into some question and answer. So without further ado, Louise.
Thank you very much, Dom, and good morning to colleagues in the UK. And I hope this finds you well. I'm glad that you've got up early to listen to this presentation, and I really encourage you and hope you feel engaged to communicate and to share your experience and knowledge on this important topic. Okay, so this is where I work. I work at Macquarie University in Sydney, Australia. We are at the end of our Tuesday, so you're going to have a great day, everyone. And I'm thinking also, and just want to put a call out to all of you. I know this year, 2020, has been, as we hear here all the time, an unprecedented year, a very challenging year. And I think one thing we've been fortunate to be is living in an island here in Australia, in that our borders have been closed, and really we haven't had to deal with the huge losses that you have in the UK from the coronavirus and this challenging year. So just my wishes go to all of you who have been significantly affected by that. Just trying to move it to the next slide. So this is where I'm from. Some of you may have been to Australia. You're most welcome to come and visit us. Sydney, beautiful beaches. We're moving into spring weather at the moment, so the cherry blossoms are out and it's a beautiful season. We're starting to get 25 degrees, 28 degrees, I think it's going to be tomorrow. So the weather is certainly warming up. This is our team. Oh, having a couple of issues managing this screen here, Dom. This is our team. We're known as the ALERT program at Macquarie University. It stands for the Australian Lymphoedema Education, Research and Treatment Program. We fit within the Faculty of Medicine, Health and Human Sciences at Macquarie University. I thought I'd do a COVID style photo of our team because we've all been doing lots of Zoom this year. Our program is multidisciplinary, and we're actually a national and now international flagship program, and we were recently recognised by Learn in the United States as one of the Learn Centres of Excellence, which we're really proud about. So education, research and treatment. Education, we actually offer CPD programs and education for health professionals wanting to become specialists in lymphedema management. We're involved in both internal and externally funded research studies looking at gaining better outcomes in lymphedema management. And my area of real interest and passion is in the topic we're talking about today, the early detection and implementation of this model of care into clinical practice. It's my vision that anyone diagnosed with cancer would have access to this model of care. And our treatment arm of our program, we actually offer both conservative, surgical and diagnostic services for those at risk of or living with lymphedema. We've actually proud, we've just recently developed some online learning modules. I think a lot of providers these days have with the environment that we have, but certainly love you to look at our website and access some of our educational materials as well. Okay, so what is a prospective surveillance and early intervention model of care? I think you've come on this call today because you're interested in this model of care. It aims to detect stage 0 subclinical lymphedema or early stage 1 lymphedema, because the research shows us that if we can detect it early, we can have a much better chance of reducing the risk of developing chronic long-term lymphedema. And we all know that chronic lymphedema not only causes physical problems, but psychological, quality of life, body image issues for an individual diagnosed with cancer and one who develops lymphedema. We know from significant research that early intervention is much easier to implement. It's much easier to manage for an individual diagnosed with this condition than what later stage lymphedema is. And potentially, if we get it at this subclinical stage, it can be reversible. So early intervention that we're talking about today aims to prevent progression to the long-term chronic lymphedema. And as I've said, it's my vision that every person at risk of developing lymphedema following cancer treatment can have access to this model of care. So what are the key aspects involved in this model of care? I guess we're talking initially about screening or surveillance, monitoring, to try to pick up the earliest signs of subclinical lymphedema. Because as we know, subclinical lymphedema is not usually visible to the eye. And so we need to be really careful in diagnosing it early, picking up the very early signs. And often that's through bioimpedence spectroscopy, where it's picking up early subclinical changes or changes in extracellular fluid levels. Ideally, we want to start this model of care at the time of cancer diagnosis at baseline. And then we want to introduce a screening or surveillance program at regular intervals for the first 2 to 3 years after someone's diagnosed with cancer. And it's important to risk stratify an individual, because a person who might have had one sentinel node removed and some breast conservation surgery and some radiotherapy is at a much different rate of incidence of lymphedema compared with someone diagnosed with 30 positive lymph nodes under the axilla, having a mastectomy and needing full chemotherapy and radiotherapy treatment. So risk stratification is really important, and our education is really important to the individual according to the level of risk. I don't think it's just a blanket. We should be giving the same education for every single person at risk of lymphedema. So assessment is really important, and assessment that we can do at regular intervals, getting a baseline and then following this person long term. Because we know that probably the most common time of developing lymphedema is in that first 2 to 3 year window after diagnosis. But some of us working in this area knows that sometimes it can be long-term as well. So having some baseline measurements and following at regular intervals, we can certainly in a better place to detect those earlier changes. Then we want to implement early intervention. That means education. Ongoing education. I often describe it to be a drip filtering of education at regular intervals when a person can take on that information, rather than all at the beginning when they're still going through the anxiety and stress of a cancer diagnosis. Exercise is important. Compression garments are important if someone detects some subclinical changes. And then just general cancer rehabilitation. So we want to make sure that somebody doesn't end up with biomechanical issues with their shoulder because they haven't been monitored and screened from early on. And we know the benefits of exercise through cancer rehabilitation. So why should we adopt this model of care? There's been a significant and growing amount of evidence, both clinical evidence in the scientific literature and also governance evidence. And I'm not going to go through all of these, but you've got some UK documents, position statements, recommendations from key cancer and lymphedema organisations who have all recognised the importance of the literature and are now endorsing this model of care. Ideally, people are monitored, people are surveilled to detect early subclinical lymphedema. And again, this is a busy slide, but it's just showing every year it's growing with the amount of evidence that's being published, looking at prospective and retrospective studies on the incidence of lymphedema and implementing this model of care. So many of you would be aware of bioimpedance spectroscopy. Some might call it BIS or some might call it LDEX. LDEX is the unit that we monitor it with. You may be familiar with the older device down the bottom here where a person is lying to have the measurements taken, and that's known as the U400 device, or the newer device that's standing here on the right-hand side called the SOZO device. Both are bioimpedance spectroscopy devices. Both have been validated to measure the same thing. I've actually been involved in some validation research that they both measure the same thing. And you can actually take those measurements in sitting or standing using the old U400 to compare it with the new SOZO. And when we did that, we found that the two devices are very, very accurate and measuring the same thing. The only proviso there is that if you're changing from using the U400 previous older device and going to the standing SOZO device, then you may get a slight difference in the actual LDEX measurement, and that's because of the change in the measurement distance of where the electrodes are placed to take those measurements. So just be aware, you don't want to interchange between the measurements because you're actually measuring at a slightly different place between the devices because of the positioning of the electrodes. So the journey, this model of care is ideally at time of diagnosis, we do a pre-breast cancer treatment assessment. What's going on? Does this person have pre-surgical biomechanical problems with their shoulder before they even go into surgery? Have they got arthritis? Have they got a rotator cuff injury? Anything pre-existing? Then we want to take baseline measurements and begin the education journey. And then we continue that journey walking side by side with the individual, ongoing education, rehabilitation, support, and early intervention as appropriate. The monitoring protocol that's been set out in Australia and commonly in a lot of the international studies is 3 to 6 monthly monitoring intervals for at least the first 2 years post-diagnosis. Both arms should be measured. If you're using the BIS technology, both arms are going to be measured at the same time. If you don't have access to BIS technology, then using circumference measurements could suffice. But remember that if we're picking subclinical lymphedema, we know that a change of volume of 10% between arms is what is clinical lymphedema. So you need to be looking between 5 and less than 10% volume change if you're using the tape measure. And we know that there are some challenges in using the tape measure at times with inter-rater reliability and to do that serial monitoring. The early intervention protocol for when someone triggers subclinical lymphedema is fitting of a compression garment, generally a compression sleeve and gauntlet, not just one or the other, but both. Class 2 or 23 to 32 millimeters of mercury compression garment. It must fit appropriately. And I really stress that. So often we think early intervention, they'll just fit into the cheapest and circular knit sleeve off the shelf ready to wear. But you just need to be aware that you need to fit the sleeve appropriately so that sometimes you might get a person who's got a very small wrist and a very wide upper arm. They may not adequately fit into a ready-to-wear circular knit garment. So the key for the early intervention in relation to compression is that it must fit appropriately. Ongoing review when someone has a compression sleeve. So I would usually measure them again at 4 weeks, 4 to 6 weeks after fitting the sleeve. And I wouldn't then take it off straight away. So in clinical research studies, the protocols are often 4 to 6 weeks of the intervention of wearing a compression sleeve. But in routine clinical practice, I would really be listening to the patient and I wouldn't necessarily be taking it straight off after that 4 to 6 week period. It depends on what other factors that woman's going through, what's the seasons? They wouldn't be taking a sleeve off in the middle of summer. So listening and using all of your clinical reasoning skills to assess when you might wean someone from their garment. I've mentioned about our education in risk minimisation and also the importance of exercise. So when we're developing this model of care, some of the things that I think are really important, that the challenges these days are that we have the evidence to show this model of care works. It's a bit of a no-brainer that this is the way we should be working, except in Australia, and I believe in the UK and the US, it's not just standard routine practice at this point in time. So what's the challenge in going from knowing that the evidence is showing us early detection, early intervention is best practice, but how do we actually get it there? And these are some of the things I would suggest considering if you think, no, we need to make this happen in our clinic. So I think a big part is about collaborative, multidisciplinary teamwork. It's not just one health professional who can make this work. You need the support from the whole team. You need to have a monitoring protocol and a clinical pathway in place. So what will happen if a patient triggers? Who will conduct the early intervention, and what does the clinical pathway mean of early intervention in your clinical setting? We need to consider this ongoing and initial education. Who's going to make that education? Who's going to make referrals? Who's going to be the specialist seeing these people? Also need to educate our team members. So educating our medical professionals, our surgeons, our oncologists, our breast care nurses, and the wider team so that everybody's on board and really is empowered that this is the model of care that you're going to work with. We need to try to have a quality improvement cycle and an evaluation into what we're doing. So collecting data and being able to review that data to see if you're making a difference or a change to practice, does it make a change in the outcomes for the individual women going through your service? And then I guess there's also the program resources to consider, whether it's funding for trained staff or funding for equipment. How is this going to work? And I think the key is that a planning process needs to occur if you're going to be able to establish this model of care. It's not something that just one person can say, we're going to do it and we're going to do it from tomorrow. There needs some planning, some engagement, some education to make it work. I'm just going to share with you two examples of how this clinical path may work in your setting. So initially, really important to get people on board. You want a champion breast surgeon or a champion oncologist who's going to support you in making this happen. You need to educate the whole team. And so by doing that, you're educating them in the model of care, you're educating them in the evidence supporting this medical care. A lot of medicos are really keen to see that clinical scientific evidence, and we've got that now. And if anybody needs access or help into getting that evidence together, I can certainly help you there. Then you need to have that routine and ongoing LDEX screening, the bioimpedence screening or tape measure, whatever you're doing, we need to implement that routine screening. Need to decide who's going to do that screening, because it doesn't necessarily have to be your lymphedema qualified therapist or registered nurse who's going to do the screening. We've actually trained research assistants, we've trained enrolled nurses, we've even trained admin staff to take these readings for an individual woman as they come in and check into our clinic. The key is, what is the pathway for when early intervention is triggered to ensure that the individual is fitted appropriately with the early intervention and ongoing monitoring. And I guess just making sure that the whole ongoing rehabilitation needs are met and that they're fitted with that appropriate sleeve when early intervention is deemed. We tend to use a 2 standard deviation from the norm, a 6.5 LDEX change from baseline as our triggering point. But we're always monitoring. If that LDEX is going up and it's just under that, well, maybe I would intervene at that point, taking into account what else is happening for that individual. Are they going through a taxane chemotherapy, which is causing fluid retention in all parts of their body? What's going on? We've always got to be listening to the individual and working out what's going on around them. In the private setting, here in Australia, we have both a public and a private setting. I guess where we can have the option of perhaps the specialist lymphedema healthcare professional being involved as the driver within the multidisciplinary team. But again, nothing happens on its own. So you need that education to the support to the multidisciplinary team, and the lymphedema therapist or lymphedema nurse can then be involved in that pre-treatment education, the pre-treatment monitoring, and then the ongoing monitoring and early intervention to ensure that we get this intervention in a very timely way. Always ongoing review, always listen to the individual patient. So thank you for your attendance. I have got here a little promotion of a little webinar that we're doing in a couple of weeks looking at ICG and how we personalise care for individuals that I'd certainly invite you to attend. And I'd like to hand over now to Ali, who's going to continue the discussion and how she's used this model of care in a local UK setting. Thanks, Ali.
Thank you, Louise. Thanks very much. Just waiting for the presentation.
You should have the screen now, Ali.
I haven't got it yet.
There we go.
No. Yeah, got it. Thank you very much. Thank you, Louise. Thank you, Dom, for inviting me to talk today. I'm the lymphedema nurse specialist at St Margaret's Hospice in Yeovil and Taunton, which covers pretty much all of Somerset, barring North Somerset. We have a big caseload of about 1,400 patients. From the breast care referral point of view, we probably have between 100 and 150 referrals each year. So today I really want to talk to you about how we set up our prevention service, why we set it up, how we did it, the barriers that we encountered, which were considerable at the time, the implementation and how we evaluate the service ongoing. So it all started really back in, I think it was 2009, when I attended the British Lymphology Society conference, and Louise was talking, presenting about recognition and early detection of subclinical edema using the LDEX, bioimpedence. And it really interested me and fired me up to go back to the hospice with a plan, which wasn't exactly an easy plan. But at the time, we were seeing a lot of increased referrals from breast care, but not only an increased amount of referrals, but they were late referrals. We were getting a lot of patients referred to us with excess volumes of 30% plus. They had severe tissue changes. The edema was turning to fat. They were hard to treat. It was a big strain on our resources because we had to do a lot of intensive bandaging. We had to do a lot of manual lymphatic drainage, a lot of flat net hosiery post-bandaging, which is a high cost for us. But most of all, it was the patient's experience of the lymphedema and the impact that it had on their daily lives. They couldn't work, some of them. It was their body image. People were asking them what was wrong with their arms. They had loss of function. It was a constant reminder of their cancer. And we were getting variable results after treatment because of the lateness of referral. One of the reasons was that we work in a hospice and all our referrals come from our local hospitals, mainly from Taunton, some from Yeovil at that time as well. The breast care nurses in Taunton do not do any lymphedema management at all. So patients got very little advice on what to do, what to look for. So very often nobody actually diagnosed their lymphedema at an early stage anyway. But the breast care nurse at that time was also very, very protective of her patients and was reluctant to refer them to a hospice. So that was another problem that we had. Sorry, Doesn't seem to be moving on. Right, okay. So I had to go back, full of enthusiasm, fired up by Louise's presentation. Had to get some buy-in from everybody. First of all, from the team. I wanted to get the team on board. That was easy because we could all see that it was going to benefit our patients. So getting the team on board was, well, that was the easy part. Everyone was behind me. Even though it was going to increase our work, we could all see that it was going to be a great benefit to the patients. Managers also have very supportive managers at our hospice. They took a little more persuading. It was hugely going to increase our referral rate. So there would be a cost involved. It was more going to be a long-term saving from a cost point of view, from their point of view. However, quality of life for our patients, particularly working in a hospice, I think is very, very important. So they were on board, but obviously we needed to get funding. With their support, that was an added advantage. The breast care team at Yeovil and Taunton, the Yeovil nurses already did some lymphedema management, so they were very keen to support us. Taunton was a little more difficult at the time because there wasn't any tangible benefit to them personally. There was benefit to their patients, but actually it was going to increase their workload. They were going to have to buy equipment. They were going to have to increase their workload by actually doing the pre-op measurement for us. And they needed to see, well, the benefit for them was actually only going to be quality of life for their patients, which was of course important to them, but it wasn't as, they didn't see the long-term effects of lymphedema as much as we did. So we had a lot of work to do there. Same with the surgeons. And then we had to get their buy-in, and we did have some hiccups along the way, particularly with our medical colleagues. We had one who's very supportive, one not so supportive, but I actually can be quite persuasive and a bit like a terrier with a bone when I get my teeth into something, and determination won through in the end. We are a commission service. We've got a ring-fenced budget for service delivery, but obviously we needed to put this forward to our commissioners. We are incredibly lucky in Somerset. We have an amazing lymphedema service. We have supportive, beyond supportive commissioners here. We've built up, I think, because when I started, goodness knows how many years ago, nearly 20 years ago, we had a very small service, and at that time we were developing service level agreements. We were working really closely with our commissioner, who was with us for a long time. He's now moved up the ladder a bit, but we developed a really good relationship, always very supportive of our service. And as long as we had the research base behind it, and there was some research at that time, not as much as there is now, but he was very, very supportive of us because he cared about patients. He really cared about patients' quality of life. So if we could prove that we were going to improve their quality of life, but keep our costings down, that they would support us. And this is where we were really, really lucky. Patients themselves, I'm going to move on to this a little in a minute, the barriers that we encountered. But we wanted to get an idea of what patients thought of this programme that we were planning to introduce, because after all, it's all about the patients. So our existing patients, we sort of mooted the idea of, how would you have felt, do you think, at the time of diagnosis? You've had more information, closer monitoring, and they were all really, really keen, proactive, thinking this would have been wonderful for us, and if you can do that for somebody else, we would certainly, support you with that. And that was useful to take back to the commissioners and also to the breast care team. I think that was one of the most valuable factors, is the patient's voice. A little snow here. Okay, barriers that we encountered. Right, the first one really, it was one of the biggest ones, which surprised all of us, I think, in the lymphedema team. But looking back, I suppose we could understand why now. But there was considerable anxiety amongst the breast care team and amongst, the nurses and the surgeons, that surveillance was actually going to increase patients' anxiety about developing lymphedema. It has obviously, it had been discussed pre-op previously. They had to sign their consent forms. Yes, it's a risk, but it was very much skirted over. So patients weren't really aware of the impact of it, how common it was then. It was, if you had auxiliary clearance, auxiliary radiotherapy, you had at least a 1 in 4 chance of developing lymphedema, and often very much higher. So they were worried that if we talked about lymphedema pre-op and then we were surveilling the monitoring them long term, it was actually going to increase their risk. So how did we get across that? First of all, we started to do some education sessions with the breast care team, but also amongst the newly diagnosed patients. We would go over to the hospital and we would talk to them. And we sort of got feedback, really, that they were interested in what we had to say. Many of them had a deep-seated fear of lymphedema. They knew somebody who'd had it. They had an aunt, they had a friend who'd had a massive arm. And it was, it was a fear that they often didn't talk about, but it was there. Funding also was a massive problem. From our point of view, our commissioners had supported us, and we had funding. They bought us 2 of the old U400 machines. That was fine. But when you're working with another organisation, and especially a DGH, it's much more difficult to get funding for anything. This was new, this was innovative. There was not a lot of, well, I don't know if there was any research in the UK. We had to rely on Australia and other places. And it takes forever, absolutely forever. Now, we were really lucky at this time because there was a new breast care nurse who I'd worked with previously in the past. She did some training with us on lymphedema. She was passionate about early detection, and she really drove this forward. And in the end, she actually went to the League of Friends and they funded the machine for us. Otherwise, we'd probably still be waiting now, I think. But it was very difficult working across the 2 organisations. There was resistance to change because it was something new, it was something untried, untested. A lot of education had to be done. We did a lot of training sessions, a lot of talks to the breast care team, to the managers. We talked to patients. There was a lot of work to do in that way as well. And also the fact we were a hospice-based service, which was something that we are aware of when you're newly diagnosed with breast cancer and you're suddenly asked to go to a hospice. It's quite a hard thing for a patient to do. And we relied very much on the breast care team to reassure them. And they did a brilliant job of it. They did a brilliant job. Of course, we had some anxieties, but usually as soon as they walked through the door, they felt welcome. They felt comfortable. They had free parking. They got a cup of tea and a biscuit. That all helps. And they saw that we were, normal people. But it was hard for some patients. There were 1 or 2 who, just couldn't walk through that door. Maybe they'd had relatives die there. There's always a history, there's a story. So we could monitor them in our outreach clinics. So, there's a way around it. There's always a way around it. Right, how did we go about implementing the change? So a lot of policies, a lot of pathways, and that was probably, that's where we started. We had to have an absolutely clear referral pathway. So we were asking the breast care nurses to do a pre-op LDEX measurement on all patients who were going forward to surgery, whether it was to clearance, to central node biopsy, because we didn't know what surgery they were going to have. They often had an idea if they were going to need clearance, but there's always the surprises. So everybody had a pre-op measurement. Well, I say everybody. It probably took 18 months before we got to the 95% mark. It started off at about 30, but we got there. We got there in the end. It was done in the pre-op assessment clinic, so we had to train the staff there. The nurse practitioners who were doing the clinic, and also a healthcare assistant who was actually doing the measurements. We also wanted them to explain a little bit about, why we were doing the monitoring. We were going to do this in more detail, but patients needed to understand where they were going to be referred, how they were going to be monitored, and the importance of it, and some basic education, just early education about minimizing the risk of lymphedema developing. So anybody who went forward to auxiliary clearance, had auxiliary radiotherapy, had positive nodes, was referred on to us, and we had our own treatment pathway. We developed a patient education program for these high-risk patients. They came in a group and we talked to them about the program. We did their first measurement and we gave them advice on how to care for their limb, exercise, skin care, weight management. We have a movement to music group, which we really encourage them to drop into to give them the exercise. At that time, we also had a swimming group, which has now been taken over by the hospital and which is working really well for these patients. But it was also a support for them. They chatted, they talked to each other about their experiences, the good bits, the bad bits. And from that point of view, they were supporting each other. Training our own staff, our healthcare assistants, we changed our skill mix a little bit. So we would do the talk ourselves. We would ask patients if they had any concerns. We would see them individually. But the basic measurements were done by our healthcare assistants, who are highly trained in the use of the LDEX. They know exactly what to look out for. They can read the cold plots. They know when to refer on. And they provide amazing support for the patients as well, because they get less support now. They're monitored much less closely in breast care. We're seeing them every 3 months for 2 years. So we're not only doing lymphedema management, but we're supporting them. We are giving them psychological support. We're knowing when to refer back to breast care, because that can be a scary thing for these patients when they're not getting regular follow-ups in breast care. So it had a lot of bonuses. Also picking up, the LDEX is wonderful, but it's, we do a full clinical examination. We picked up a lot of breast edemas, which may not have been picked up before, hand edemas. There's a lot. It wasn't just a measurement. There's so much more to it than that. So finally, we have to evaluate the service. We do regular audit, which we present back to our commissioners. The first audit we did, this was when we were monitoring patients every 3 months for 3 years. We've now, as a result of that audit, and because our resources are, they're tight, and we have to work for all our patients. We're a non-cancer service as well, so we have a lot of patients, and we have to look after them too. We reduced our surveillance program from 3 years to 2, because we found that the vast majority of patients did develop any sort of subclinical or established edema within 2 years. Some later, obviously, but that was the majority, so that is why we decided to do that. Our patients themselves would love to be monitored forever, I would say. Unfortunately, we can't do that, but obviously, if they come back with a problem, we've got all their data, so we can refer back to it. So our audit has been really, really positive. We are looking back prior to this program, we have reduced considerably the amount of moderate severe edemas that we have. We have found that we can, say, reverse the edema with early intervention. We use a class 2 compression sleeve where possible for the first 8 weeks usually. And then we wean our patients off gradually, and we are finding a good majority of them are returning back to their normal pre-subclinical levels, pre-op levels. We do encourage them, especially if they're young, active. We've got a lot of farmers in this area who are humping bales of straw, to wear their sleeves if they're doing really severe physical activity. Some of them progress to develop lymphedema. It's not, cure-all by any means at all, but they seem to stay, virtually all of them, within the mild range, which is obviously much better for them. There are periods they can leave their sleeve off. They can more likely to be able to wear the thinner, ready to wear sleeves. We're doing much less bandaging, and I'm saying we were. We'll come on to that in a minute. And the quality of life, the patient feedback, we've done questionnaires, and it has all been positive. They're very up. We're in danger of losing this program at one point, and we hurriedly sent out questionnaires to patients, and one a day again by patient voice, which is really, really important for us. So the future, really. Can't go without mentioning COVID, I'm afraid. We've been incredibly lucky here in the Southwest so far, touch wood. But obviously we did lockdown for 3 months. Our services stopped from, I think it was the 20th of March, and we opened up again, I think it was about, July. It was the first week in July, because they, obviously being a hospice and inpatient unit, we were being, had to be very, very mindful of our hospice patients. It has had an impact on our surveillance program, and it's interesting that it has had that impact, that we've not been able to do our monitoring. We moved over to telephone and video consultations. You cannot do a telephone and a video consultation on a person who has subclinical lymphedema, because they have no signs and symptoms. So we did not pick up, and we have missed some, and that is showing now. We've got 3 patients in bandaging at the moment that we missed because of this, and they were early symptoms that actually suddenly took off. And more probably in the pipeline as we're gradually catching up, because we haven't caught up with everyone. So that's one of the impacts. The other impact, they didn't get a pre-op measurement. All pre-op assessment was done by phone for the breast cancer surgeries, which were done at the private hospital. Obviously much reduced service as well. So with no pre-op measurements, it makes it more difficult when we see these patients as we are now, because we have no baseline. So if, for example, they may have had a pre-operation measurement, if they'd had one of -4, and we see them and they've got a measurement now of +4, that's the movement at 10, but we wouldn't know it. So we're a bit stabbing in the dark again with the impact of COVID, and it's still not as we wish. We're still not getting all the baselines. We've got vastly reduced referrals as well. We've gone down from sort of 12, 15 a month to 1, 2, 3, which is a worry for us. We're now also beginning to work with the gynae patients who've had bilateral node dissection. Few numbers in our area, but we are beginning to work with them. Too early yet to say what results we're getting. Hopefully we're going to be looking at that at the beginning of next year, but obviously there's, with COVID again, there's a delay with that. Melanomas we've been working with for quite a while, so any melanoma patient who's having axillary or groin dissection comes actually to the hospice for a pre-op assessment of baseline, and then we monitor them, and again we're having good results with them. And with the new SOZO, we can measure bilateral lymphedema, both so we can do the bilateral gynae patients, we can do bilateral breast cancer patients, which has been a massive benefit for us. So thank you very much for listening. Hope to try and answer any questions you may have. Thank you.
Perfect. Well, thank you, Ali and Louise. We'll get into some questions. I know there's a question that's popped up a little early from Karen Cooper. So Louise, Karen's asking, what are your thoughts on fluoroscopy pre-surgery to track the working lymph vessels in order to preserve as much as possible?
Thanks, Don, and thanks for the question, Karen. Ideally, I would love to do fluoroscopy measurements or imaging on patients before surgery. It's not something we're doing at all routinely. I think probably just the invasiveness of the imaging and the associated stress at the time of a person's diagnosis. At the moment, we're certainly not doing it. But we are starting to do a little bit of ICG imaging for patients after surgery, perhaps before radiotherapy, or in the early stages while they're still going through treatment, for particularly those at higher risk. And we've just recently did a lady who we saw just prior to radiation and then 6 months later, and had some really good results because we were able to really give her a personalised treatment plan of how to do her own self-massage based on her lymphatic anatomy and what lymphatic vessels were functioning well. So I think there's a watch this space. We're certainly very interested in the ICG imaging technology and what it potentially can do. It's certainly changing our practice in our MLD, both from an education point of view and teaching self-massage for patients based on the pathways that we're identifying. To watch this space, I think there's scope for a lot of information to gain.
Perfect. No, I just wanted to ask as well, is like, because one of the things that we always get is the word around the word prevention, which I know you've sort of, Louise, I know you sort of defined earlier, but I just wanted to hear from both of you. Louise, first off, is I just want to be super clear on the word preventing. What are we preventing? And do you use prevention with patients? In what context do you use that word?
Thanks, Dom. I guess I don't tend to say the word prevent lymphedema for my patients. The reason I don't say it is because that we can be doing this amazing screening, prospective model of care. And like Ali referred to, sometimes you can't prevent lymphedema. Because of the risk factors and the individual's anatomy and treatment they're having, sometimes we're not going to be able to prevent it even though they're slotted into this model of care. I still think for those patients, we're giving them a much better outcome than if we weren't doing this model of care. So I tend to say we're employing this model of care. I call it a model of care. It's not about a piece of equipment to just do the monitoring. You know, you're not, I say to the companies, you're not selling a piece of equipment. You're actually selling or adopting a model of care. So it's all part of the package of care. It's part of the education about what is lymphedema, what are the signs and symptoms to look out for, and having some objective tools and measurements can help to detect early signs or symptoms of lymphedema so that we can intervene at the most earliest and effective time. So that's my terminology that I tend to use with my patients. And, you know I'm involved, we're one of the 10 sites, we're the only site outside of the US involved in the very large PREVENT study. And, you know, the name for the study is called PREVENT. But, you know, even with that study, there's patients who have still gone on and developed lymphedema. So I'm a little bit cautious in the wording of it, because you can get some patients who might say, but I did everything you told me and I still developed lymphedema. So it's like, let's do whatever we can to try to reduce your risk of developing this condition, and then do whatever we can if we detect any early signs to manage it effectively.
And Ali, have you got any comments on that as well?
Yeah, totally agree. We never use the word prevent because we can't prevent it. So we're very much focusing on the monitoring, detection of any slight changes in that limb, and early intervention, and the importance. And it's, as Louise says, it's the constant education, because sometimes, you know, we will see a rise in a patient's LDEX, and sometimes the patients don't want to wear a compression sleeve at that point. So, you know, a lot do. I would say the majority absolutely do, but you will get some people that actually wearing a compression sleeve, it's the most horrific thing that they can think of. You know, they just can't cope with it. And that is the patient that we bring back really frequently. And with the FOZO now, obviously, when we had the U400, we had to keep buying electrodes. That had a cost implication for us. So now we can bring people back much more frequently and monitor them. And, you know, we can work with them and support them. And I can hardly think of any who long-term have refused when they see that score beginning to increase. So they'd love us to prevent it, of course they would, but we would never use that word, because you know, we are getting patients that develop it mildly, but you know, even if it's mild and you've got to wear a compression sleeve, you've got lymphedema and you've got to live with that.
Yeah. So Ali, I just wanted to add as well, because you mentioned obviously yours is a commission service, which is amazing. I mean, double barrel question really is one, how did that happen? And why do you think it's not necessarily commissioned elsewhere? I'm not privy to, obviously there's probably going to be other services that might have some form of model of care in action, but why do you think it's not something that is sort of nationally recognised as a pathway?
That's a difficult one, because we are so lucky here. I think timing was actually part of it, because if you look back to 2009, we had more money, basically. And our PCT, as it was then, they did have more money. And it's tighter now, and it's going to be tighter still. Yeah. I think you've got to have an amazingly good relationship with your commissioners, which takes a long time. We were lucky because we had continuity, because our commissioning manager for lymphedema, we had him for something like 10, 12 years, which is actually very unusual, I think, in commissioning's world. So we had a good relationship. It was hard work. I think you've just got to keep at it and provide the evidence. Yeah. And I think it's got to be financial evidence, and you've got to prove that it's cost effective, but also, you know, look at the quality of life of patients. I did a lot of case studies. I actually took a patient with me to one meeting. I took hosiery, I took flat knit hosiery, I took round knit hosiery, and some quite glamorous ladies on our commissioning board. You know, if you had to wear one of those, what would you wear? You've got to appeal to the person, I think, as well. But it's got to be a robust business case, obviously, as well. But a combination.
I was going to mention that on the financial aspect. Have you seen like a definite improvement in terms of cost saving as well as time for you guys in clinic as well?
Yeah, because we can change our skill mix. We've now got healthcare assistants who are really, really highly skilled. So we're freeing up more specialist time for other things. We're not having to do the intensive bandaging. We're not doing so much MLD. And the majority of patients we can fit into a ready to wear. Not all of them, as Louise says. Some of them will need custom made, but the majority are in ready to wear. And if they're wearing it infrequently, we don't have to provide so much of it. So it is cost effective, and we have proved that.
Perfect. Well, thanks for that. And Louise, Andy just asked the pros and cons of perometry versus sort of bioimpedance or LBEX. Should we be using both, one or the other? Because I know it comes up a lot in conversation of one versus the other. What is your opinion on that, Louise?
I guess in the Australian setting, perometry is very rare to have in a normal lymphedema clinic. So the Perometer costs a significant amount of money for us to have out here, and really only large clinics or research sort of clinics have it. And so if you're talking about volume measurements versus bioimpedance, generally it's the tape measure. And we know that there are challenges with the tape measure. So I think if you had access to perometry and you could do a 30-second measurement and use it as an adjunct tool to the BIS technology, there's possibly benefits to that. You've got to be aware that you take account of your dominance factor. And I think perometry, depending on the model of perometer you have, you've just got to be really careful that you have the same angle so that you're measuring that exact same angle, that you're getting that consistency and reliability in your measurements. And I guess the challenge with, if you don't have perometer, taking circumference measurements is more time consuming, a lot more time consuming than perometer. And I guess if you really look at the evidence, and I was just this afternoon doing a review for a journal manuscript that someone submitted for publication, which was a meta-analysis comparing circumference measurements versus bioimpedance spectroscopy, and they've done a significant review. It's a really good article, which I'm sure will get published, and it really showed that the BIS technology is really the one that's validated for the subclinical detection. So even though you might take the perometry or the circumference measurements with a good standard protocol, it's really the change in the extracellular fluid levels that is going to really be your reading for triggering some clinical lymphedema that we're talking about as part of this model of care.
Okay, Ali, have you got any comments on that as well?
Well, we do have a Perometer because our patients fundraised for it and bought us one, which was like an amazing feat. But so we don't use it for our arm edemas because we've got the stand one, not the portable one, and we don't find it useful for that. That's our opinion. We use it a lot for lower limb, but only for our established edema. We don't use it as our surveillance program at all. Although before we had the SOZO, we did use it for our gynae patients.
Yeah.
But we don't use it for that. We use it for our established lower limb edemas.
Yeah.
Because
the two different
sensitive
technologies, aren't they, that are applied in different ways. I think understanding that is important.
Yeah.
Perfect. So I'm just going on to the pathways. So Louise, you must be exposed to pathways worldwide. I know you well travelled, obviously not at the moment. Where do you think the UK sits in terms of implementing this model of care, with or without BIS? Are we sort of, to put it bluntly, are we behind? Are we on par with other countries? I mean, have you got any comments around that?
Hard question, Dom. I think a lot of the literature, the scientific literature, is coming out of the US. And I think Australia is possibly a little bit of ahead of the world, I have to say, with this implementation of using this technology. One, it's an Australian technology, so it's been around possibly a lot longer in this country, and it was really targeted to lymphedema professionals and lymphedema therapists initially in Australia, whereas in some other countries, I think the target of selling these devices was more to the medicos or the surgeons. And I think, that's possibly been a little bit different. I think though, worldwide, I know Vaughan Keeley is presenting at the Learn Virtual Summit this weekend on the model of care and early detection of breast cancer related lymphedema. So I think it is happening. And I think it's also an issue that women diagnosed with breast cancer are big advocates for this model of care. And I know in Australia, lymphedema is still one of the top issues relevant to cancer survivors after breast cancer. Whereas if you'd ask a breast surgeon or a medical oncologist, where does lymphedema fit in breast cancer management, I don't know that they would necessarily put it into one of the top 5 issues for cancer survivors. Whereas for women, and even if it's, a 1 in 5 chance of getting lymphedema, because of that outward sign that there's something wrong with my arm, I can't hide the fact I've had breast cancer, it becomes a big issue. So I think we're all doing things now internationally. And I think with the push of some of these big studies, there was a big study published in the UK, there's the big PREVENT study that I'm involved in. I think over the next, 5 years or so, I think we're hopefully going to see a big change. And I think the challenge will be, with some of these big studies being published, the challenge is going to be, how do we implement it? So, that we understand the model of care, but what's the next step in getting the funders on board so that we can roll it out, that everyone has access to it? Yeah.
I mean, Ali, from the UK's perspective, obviously, you're NHS, and implementing the pathway in the NHS throws up its challenges and lots of different red tapes and everything else. From an objective perspective, would you want to see more private provision? I know I can't name them, but I know there's some private hospital groups that are looking into it. Would you like to see more provision on the private as well as NHS side of things?
Absolutely, like to see it everywhere. Yeah, talking, locally from our own private hospital, we are missing patients who've had their surgery privately. although it's improving now because our one of our surgeons does, in fact he was the one who was most anti, so we've obviously done something right. He will often refer his patients for monitoring from his private surgery, but it has been a problem, and I'm sure it's a problem everywhere. I've got a daughter now who's just started work in a private hospital in London, actually, so I'm getting her on the case. So I think absolutely, I think the more of everywhere should be doing it. It's the outcomes of, they're so important for our patients, and that it's changed our type of patients we see completely. And I think it should be one of our priorities. Prevention, well, prevention, I'm saying that again, but actually, it should be one of our priorities. And it's hard to treat an established edema. It's hard to get a good result. And it's I think we've got to keep fighting for it.
Louise mentioned about the model of care, and obviously hopefully over the next sort of 5 years or so, as more people are going to implement it. Is there a standard care model, or can it be adjusted for each place? Obviously, everywhere's so individual, isn't it? So, can that model, in your opinion, your experience, can it be tweaked and changed depending on that provision that's in each trust?
I think it can, and I guess why I presented those two examples today. We have the two different health systems, the public health system, which is probably similar to your NHS, and then we do have the private health system as well. And I know when I've seen women over the years who have come through my practice and had access to this good model of care with all the education, they feel empowered, they're being monitored. When I sometimes get patients who haven't had access to that model of care, and then they get referred to see me because they've got some problems, either with swelling or symptoms or questions about lymphedema, and then they get referred to see me, after I've initially assessed them and worked with them to develop, a management plan, if I mention that, my other patients have had access to this from when they were diagnosed, they actually feel really ripped off and quite upset that they weren't offered that same level of care. Whether it's through the public or private, sometimes it doesn't matter. But the women, I think, are going to be part of the driver in helping to get this model of care off the ground. In Australia, we often say breast prostheses for women who've had mastectomies previously wasn't a government funded thing years ago until women lobbied for it. And now every woman gets a new breast prosthesis every 2 years, no questions asked. Oh, wow. So I think, if this, can get the momentum from those consumers, we often say when we're talking to people, we need that high celebrity or the politician's wife getting this condition to start putting pressure, on the health systems, then we're going to make a difference. I don't wish any bad on anyone, but I think, we do need some support from some high profile people to help advocate for this. Yeah.
And Ali, I mean, obviously you've implemented this from scratch, I know, which is a hard way. Would you say that being persistent and patient was key to it, of being able to implement this down south?
Persistent, definitely. Very persistent. I'm not known for my patience, but I do tend to find things very simple, and then I get quite frustrated when they're not. But yes, you do have to be patient. It took us, before we felt that the pathway was running as we hoped, it probably was 2 years, to be honest, working across two sites. I think if you're not working across it with two organisations, it's probably easier from that point of view. But persistence, absolutely, and getting the patient voice behind you as well is absolutely crucial. It's powerful. Yeah.
So, I mean, on that, because I know we've run a little bit over because we had a few questions I wanted to just get through. So, Louise, from your perspective, a couple of things. Who are the two people, job titles, whatever it is, that you would recommend approaching and trying to get on board? And then is there like one little nugget of advice to anybody who's looking to take on a project like this, what nugget of advice would you give them?
Well, I think, like I said earlier, I think it's got to be almost seen and recognised as a team project. You need a multidisciplinary team because you need buy-in. You need buy-in from the medical professionals, the surgeons, the oncologists. They don't necessarily have to have the knowledge about it, but they need to know the evidence that's supporting it, and they need to be supporting, whether it's the breast care nurse, the lymphedema therapist. We need some champions together to say we can do this and we can offer this service to everyone. So I think the education and, you know, obviously people who have come early on the morning to listen to this webinar, they're obviously interested in it, and we need them to go and fly the flag and be the champions to promote this model of care.
No, for sure. And then same question to you, Ali, really, is any nuggets of advice from your experience that you can share?
You need the support of your breast care team. They are very important, medical team and the nurses. And you need the support of your commissioners, because if you're a commissioned service, that's where you need the support, because without that, you're not going to get anywhere. So you have to provide the evidence. You have to do a robust business case to provide the evidence. And don't give up, because it takes a long, long time. But you've got to believe in it, be enthusiastic, don't let go.
And it's worth it in the end, yeah?
Absolutely, without a doubt. Yeah, I'm evangelical about it.
Great. Well, I'm going to have to wrap it up because I know we've run over a little bit. And I think people need to get back into clinics if they've not already gone. So I just want to thank everybody for joining us this morning. I know it's been an early start. So thank you for your attendance and also your participation as well. Ali, Louise, thank you so much for your presentations and your advice as well with all of this. Just for people that are still on, and also for people who are watching the recording after, is you will receive a survey along with the link to the recording. So we'd really appreciate your feedback on the content that we shared, and any other subjects that you'd like to hear about, please let us know and we'll look to try and put them on for you. Some upcoming webinars that we do have, we've got a couple coming up. So we have one on the 1st of October, which this week, on implementing myofascial decompression therapy, or Lymphoedema. So it's just a fact-finding webinar, so you can find out more about that. And then we have something similar around SOZO and bioimpedence for lymphedema as well. So it's all fact-finding, find out more about the technology and how it might impact you in practice. If you do have any other questions, then please feel free to reach out to PhysiQuip on our email, info@physiquip.com, and we'll get those answered for you. Otherwise, thank you very much for attending. Have a good day. Ali, have a good day. Louise, have a lovely evening. And we'll hopefully see you all again another time soon.
Thanks very much.
Thanks, bye.
Thanks. Bye now. Bye.